Okay, without further ado, Yuji, please share your experience and knowledge on this really important topic, and we'll do questions a little bit at the end. Okay, welcome again.
Thank you for a kind introduction, and thank you for giving me this opportunity. I'd like to share about our experience based on the new idea that embolization can reduce the inflammation or pain. So we developed this idea from 2012. And now many physicians are doing in many countries. And in US, the GAE is the genicular artery embolization, is the new technique for reducing inflammation by embolization. For the knee osteoarthritis, GAE is widely accepted in US and performing more than 1,000 cases in last year in US. And we also apply this technique to other conditions like overuse tendon disease or frozen shoulder. Those are most common disease and chronic inflammation. So my first idea was embolization, particularly using a temporary embolic material, can reduce the inflammatory vessels and reduce the inflammation and the pain. But when I first introduced this idea, nearly every physician disagrees with this idea, because if you firstly heard that embolization for joint is scary or seems to be dangerous, but using I can understand such a consider, but now the changing gradually. So I will introduce the idea and the concept and the data. Well, this is my disclosure. Now I was belonging in the university hospital and then moved to private hospital. And from 2017, I opened my own clinic, OBL, in Japan. And now we have 7 branch with angiomachine and 3 satellite branches. So totally 10 branches in Japan, mostly focus on this MSK embolization procedure. So we work with 7 full-time interventional radiologists and 3 part-time interventional radiologists. And we are now performing about 200 cases per month in many chronic disease, painful joint disease. So this is the first paper in 2013 for the first very short observation of first idea, embolization for chronic joint inflammation. And the first disease was a tendinopathy and encephalopathies containing the tennis elbow or jumper's knee or Achilles tendinopathy. And we published to JBIR the data. Let me give you one example. I think this is easy to understand the concept. 75 years old female who have 1 year history of plantar fasciitis, heel pain, common cause of heel pain, and this patients already received the total rest or physical treatment and painkiller, but the pain still remained. So this is affected area. So we applied this technique to these patients. It was 2012. And I will show you the normal appearance of posterior tibial artery angiography for some of you may not be familiar for the angiography. And this is a normal appearance of a posterior tibial artery angiography. Compared to this normal appearance, the present case, we did the angiography, and you can easily see that increased abnormal disorganized blood vessels located at the affected area. This is, and also containing the early venous feeding. We call it early venous feeding. It's a existence of micro-AV shunt. So we inserted the microcatheter from groin to the posterior tibial foot joint level and perform angiography. So catheter tip is, you can see the catheter tip in the upper, and we infuse, from here, we infuse this temporary embolic material. This is imipenem cilastatin sodium. This is originally antibiotics, but crystalline compound, so slightly soluble to water and can embolize inflamed microvessels. But in the quickly recanalize in normal vasculature. I show you later the detail of this, the difference between the normal artery and the inflammation arteries. This is a microscopic observation of the imipenem particle infused to the water. You can see mixed with the contrast. You can see the imipenem particle sometimes aggregating together and embolized in about the 200 or 250 micrometer vessels. So we use this particle and infuse in the normal artery and the inflammation artery. The left is the normal tissue behavior of imipenem compound in normal artery. Normal artery can dilate it, a little bit dilated, and fresh water keep to come. So the crystalline compound gradually dissolve in a few minutes. But compared to the normal tissue, inflammation tissue is easy to clogged, making clogged, and embolize more than 90 minutes. So this the difference of behavior to this foreign body is different between the ability of recanalization is higher in the normal artery. The left panel is before embolization angiography, and the right panel is after embolization angiography. You can see the decrease of brush. We call brush. It's like disorganized stain or brush. You can see the decrease, and also you can see the increase of normal blood flow. That is a good endpoint of this procedure. So, and the blue line is a change of pain NRS VAS score. So the pain level decreased in 50% or 60% instantly, and after 3 months, the pain becomes pain zero, and 4 years follow-up, she doesn't develop the recurrence. So we can say that this embolization procedure was effective for this patient. So we call it MSK embolization, or sometimes we do the transarterial microembolization. Is a technique aimed at reducing inflammatory vessels and leaving normal blood flow, or leaving or increasing normal blood flow. It's a new idea compared to the conventional embolization. Usually, embolization is used to stop bleeding or reduce the size of tumor by making an infarction. But this procedure is leaving the normal blood flow and reducing the inflammatory vessels. So this idea is now currently widely accepted. The most accepted disease is knee osteoarthritis. So for the knee OA, we call this procedure GAE, genicular artery embolization. And FDA approved this technique in 2022 in US. So current evidence of GAE procedures, most studies are non-controlled cohort studies. There are 3 sham control studies. The GAE is reported as safe, and the responders is around 70% or 80%. It depends on the inclusion criteria, but experience a dramatic reduction in pain and improvement in function within the first 3 months, and the benefit is maintained to report the midterm, so 1 year or 2 year follow-up. So this is meta-analysis data of GAE, 11 studies, including more than 200 patients. And they reported a similar effectiveness and the safety profile. And this is an example of 69 years of female who have medial knee pain. The left is a MRI finding of these patients. By seeing the MRI, we usually check the presence of synovitis. First, we check the presence of synovitis. These patients have medial side knee we can see the increased higher intensity area. And we also check the meniscus, surgical indication of meniscus tear, and also the bone marrow necrosis or bone marrow, such a surgical indication. So we want to exclude such a mechanical pain. We want to include the inflammatory synovitis patients. So this procedure is reduce of inflammation. So we have three criteria: the presence of synovitis and excludes mechanical pain source like meniscus surgical indication, tear, or bone marrow necrosis. So we apply this technique to these patients, and the left is MRI, and the middle is before embolization angiography. We can see the much synovitis finding and abnormal inflammation, abnormal nerve vessels, and the right panel is after embolization. So these patients, the pain score reduced dramatically and maintained for more than 1 year. So this is a table in the meta-analysis data about our, including us, but from other studies. And this is also data from UCLA, Dr. Padier, who also reported 40 patients in 2020. So technical success rate is very high. It's very high. Usually the 97% or 99% reported technical success rate. So technically, selecting the vessels is relatively easy compared to the other, for example, prostate artery embolization or something. And the efficacy. How about the efficacy? Usually, this is the data from UCLA, and the WOMAC score improved within first 1 month and maintained for 1 year. Some patients have recurrence and some patients progressively improved. So the median score, the same level compared to the 3 or 6 or 12 months. Some other reported a similar reduction of pain, but compared to the, for example, the Korean group reported the KL4. KL4 is patients having a severe damage. Compared to the KL4, the KL1 or 3 is much better results compared to KL4. So the similar data, we experience similar things. So how about the structural damage for long-term follow-up? If I introduce this idea to orthopedic surgeons, some physicians strongly claim or consider about the risk of rapid progress of knee OA. Or if you, this technique actually reduces inflammation, but it's not easy to understand. So sometimes physician knows that if you kill the nerve fiber, structural damage will occur or something. So we performed a 2 years follow-up MRI study compared to baseline and 2 years after GAE. Is our data, and 1 year after GAE by UK Mark Little data, we compare that. The progression of OA is acceptable. There is no rapid progressive osteoarthritis. So we have never seen such a problem. So the progression of OA change was acceptable, and we commonly reported the decreased synovial inflammation. So we can say that this procedure doesn't cause progressive osteoarthritis change. So mechanism. How about the mechanism? There are five animal studies to show the mechanism of this. How it works. There is one paper in JVIR about frozen shoulder model, and using a rat frozen shoulder like this, and they can develop the synovitis compared to the control group. If they do such a restriction, the synovium tissue thickened and containing lots of microvessels. So this Japanese group, Nara University group, have shown that compared to control group, if they develop the frozen shoulder model, there are lots of microvessels and mononuclear inflammatory cells. And after developing this frozen shoulder, they divided into two groups, and one group control, and the other is doing embolization using imipenem. So the data showing that compared to control group, the embolization group have less microvessels and less mononuclear inflammatory cells. So it indicating that this procedure can reduce microvessels, inflammatory vessels, and mononuclear inflammatory cells through the and similar results were reported in the knee OA model from the two studies. And recently, and last month, a new results come from Japan, Kawasaki University. They used a very fine microangiography, which can reveal the 30 micrometer blood vessels, and they observe normal capillary and inflammatory vessels. And in the normal capillary, after infusing imipenem or the other temporary embolic material like Nexfer, after 90 minutes, normal capillary recover to the baseline level in the blood flow. But compared to the normal capillary, the inflammatory vessels try to recover, but gradually decrease the blood flow. Can I use the pointer? Yeah, okay. Okay, just a moment. Yes, this one. Can you see? Yeah, these inflammatory vessels, and after 90 minutes, the decrease will disappear. After the temporary embolic infusing temporary embolic material, but normal capillary first reduced, but return to normal baseline level. But in inflammatory vessels, try to recover, but reduce in 90 minutes. So the behavior is totally different. So there are several options for using embolic material like Embosphere or Embozine or PVA. It is known as a permanent embolic material. And the lower one is a temporary embolic material. And we prefer to use a temporary to reduce side effects like skin damage or nerve damage. I will show you the data. But in US, they use a permanent microsphere. I will show you the results. But safety concern was actually, there is a safety concern by using a permanent microsphere. So I will introduce the important aspect to be considered. Safety profile is cutaneous damage, skin damage, and peripheral neuropathy and ischemic pain. It's a three important aspects by using a permanent embolic material. The UCLA study was using a permanent microsphere, and 17% have mild focal skin ulcer, and it was mostly self-resolving, but sometimes the skin color change is severe. So this is a report from Taiwanese physician who use a permanent microsphere, and they develop the color change like this or like this. So this color change improved within 1 month or 1 week or 1 month, but it's not good. So if we use a temporary embolic, we don't see such a side effect. So the peripheral neuropathy is also developed in 10% in the patients using permanent microsphere. So Dr. Bagler reported 10% patients develop plantar sensory paresthesia, numbness. But it was self-resolving, but we don't recommend to use a permanent microsphere. So this is a summary of the side effect by using a permanent microsphere. So we want to reduce this side effect, we developed, by using imipenem, but now we use NextFair F. NextFair F is the alternative temporary embolic material. I will show you later. So this is a NextFair F, is a gelatin-made sphere type embolic material. So gelatin is made by we did lots of cross-linking and the network and the cross-linking, the density of cross-linking. Modifying the density of cross-linking, we can change the biodegradable time. So the higher density cross-linking can protect the water or enzyme, and that results a longer degradation time. And lower density cross-linking can allow the water or enzyme infiltrate and faster resolving time. So this particle can, the size is around 200 or 300 or more, and the volume with reduction in 2 hours, 50% in 2 hours. So we can say that this particle will disappear in 4 hours or 8 hours. So we tested, compare the results with imipenem and the NextFair F. So the patient's number was more than 140. And but the safety data, we didn't have ischemic pain in the NextFair F, and we didn't see the numbness. So the nearly zero risk of numbness, nerve damage, and cutaneous damage. So we can say that this particle is very useful and safety profile. And compared to the imipenem, the NextFair F shows good results, better results in the tennis elbow patients or knee OA patient and jumper's knee patient. And knee OA, the results is similar, but in the tennis elbow and jumper's knee, we see the significant difference in the effectiveness. And compared to the permanent microsphere, the reduction of VAS score from baseline to 3 months is reported VAS reduction is 34 in the pooled mean pooled reduction of VAS score in the meta-analysis data was 34, and compared to that, so our data was similar and more better reduction. So, and we also can apply this technique to the tendinopathy, like Achilles tendinopathy or patellar tendinopathy. I will show you some two paper of our recent 2 paper. I will skip this one, but first one is GAE for the patellar tendinopathy, 89 patients up to 7 years follow-up. This paper is just accepted to the Orthopedic Journal of Sports Medicine. This is open journal of USA Sports Medicine. So I think you can see in the near future. But this is a summary of the data. We performed 89 patients using 56 in imipenem and 33 in NextFair F, and performing the embolization treatment for these patients. And this is a movie of the procedure. We inserted the catheter from the groin and selected the inferior lateral genicular artery, which is a very important artery for feeding the patellar tendon, and inserted microcatheter and perform angiography from here. The affected area, we can see the brush. Like here is the brush. But this is AP view, so we change to the lateral view. Lateral view, it's more easier to detect the brush here. So you can see the brush here. And after identifying the brush, we will infuse the NextFair F from here. There's a small amount, and now I put the small amount of NextFair F to the microcatheter and push by normal saline. and to infuse this particle to the affected area. So after, this is angiography after infusing NextPF. So that is the process of this procedure, and the safety profile is good, and there was no tendon rupture, and there was no dermal ulcer, or of course there was no necrosis or muscle weakness. And the pain reduction was effective, and the reduction of pain, NRS, was larger in the NextPF group. And for the 10 patients cannot go back to their full training, but almost 90% patients were able to return to full training. The median time for return to full training was 3 months, like 3.5 months. So, and I will show you the other case is plantar fasciitis, and for the other simplified puncture model. There are two methods. One is a super selective using catheter method, and the other we developed the ultrasound-guided direct puncture to the neovessels. So the plantar fasciitis is not easy to treat, and the benefit of transcatheter arterial embolization is recognized, but the challenges is we want to reduce irradiation or using a medical device. So we developed the direct puncture model. This is angiography, and if you see, we can, by using ultrasound, we can puncture this artery and can infuse the temporary embolic material. So that is the idea. So we reported this results to the European Foot and Ankle Surgery paper, that ultrasound-guided intra-arterial embolization. This is a simplified technique to reduce the procedure time. So I will show you the results of this paper and the retrospective results, and the patient's indication was plantar fascial thickness more than 4 millimeters and local tenderness. So we perform ultrasound-guided arterial puncture. I will show you the movie. This is a medical device. It's very cheap, and 25 or 27 gauge needle, extension tube, and a small syringe. That's it. And we use like this. We use the ultrasound and reveals the posterior tibial artery and the puncture, and the assistants will infuse by using a syringe. I will show you. This is a picture and baseline, and soon after infusing imipenem, and the cutaneous color return to normal within 2 minutes or 3 minutes. Not normal, the redness. And the first phase was turning white, and the brush out the red blood cells. And after that, the capillary dilated, so the cutaneous color turned to red. And 10 minutes later, the skin color returned to normal. So this is a movie of this procedure. We don't use angiomycin. We can perform this in the consultation room. So under ultrasound, you can see the needle tip is inside the posterior tibial artery, and the assistants infuse the particle. You can see the particle inside the artery, and remove the needle. That's it. So the medial procedure time is around 2 minutes. So this is angiography before and after doing this procedure. We don't take angiography in all cases, but first 10 cases we took angiography before and after to confirm the reduction of the brush. So this is a 66 patients' data of pain NRS decreased within 1 month and progressively decreased. Because we did the 2 times or 3 times in 1 patient. So some patients receive a baseline and also receive a second treatment at the 1 month later or sometimes third treatment in the 2 months. So the results progressively improved. And compared to baseline, the second plantar fascia improved after the final follow-up in the ultrasound. And nobody have a rupture of tendon. Actually, we have treated more than 800 cases of plantar fasciitis or Achilles tendinopathy, but no one has resulted in a ruptured tendon. This is very different from the results of steroid injection. Steroid injection, corticosteroids can reduce the blood vessels, not only the inflamed blood vessels, but also the normal blood vessels, and also affected negatively for the tissue. So the steroid injection can result the rupture of plantar fascia in 3% to 10%. It's well known. So our embolization technique is totally different from the steroid injection results. So I think I have introduced. Finally, I want to introduce. We are now planning to do the international MSK embolization specific congress in Japan in this November. So we are now called the BENTI meeting in November, and the BENTI means a vascular embol therapy and nerve intervention targeting inflammation and pain. So if you are somebody interested in this technique, I think this opportunity is a good opportunity to know and develop the good relationship with expertise. Thank you very much for hearing.